Thank everybody speaking also for the second talk. It's my great pleasure to bring to today Rema Padman, also from Carnegie Mellon University, the Trustees Professor of Management Science and Healthcare Informatics. She's doing a lot of good work around that space and has won several accolades there. And I'm sure we are all looking forward to your talk today. Also for taking time to join us today. Was it good enough short?
Oh, perfect. Thank you. Thank you very much. It's wonderful to be here. I know 2 1-hour talks back to back is a bit too much. And also I'm cutting into your lunch hour. So I will try and finish. I have quite a few things to say about this topic that I'm very passionate about. But I'll try and be as efficient as possible. But thank you all very much for staying back, for your interest, and for the invitation to present here. So much of my work, my work is really across healthcare informatics, healthcare analytics, and healthcare operations. My PhD is in operations research and computer science, and later on, I developed this interest in healthcare. So for much of my work in this area has been on optimization, simulation, predictions, clustering, trajectory modeling, and understanding patterns in care for both inpatient and outpatient settings, chronic diseases, infectious diseases, and so on. Over the past 5 years or so, I've become really interested in this question of health literacy. The idea being that we can develop the fanciest, the best models possible for risk prediction, for interventions, and so on. But if patients are not ready to really respond and act upon these guidelines and recommendations that are given, and do the right thing in management of self-care and so on, we really are not going to get the best results, best outcomes, health outcomes. So that has really prompted me to look at can we bring in apply these tools and techniques and models and methods that we are developing, bring it to bear in the context of health literacy. So that's really the underlying motivation for this work. And in this context, I'm looking at both adult literacy, digital tools for adult literacy, as well as pediatric literacy. So in the context of pediatric literacy, I won't talk much on that today, but I really have a neurocognitive training and implicit learning-based mobile app that we are testing out using randomized clinical trials in different parts of the world, in India, in Botswana, in Singapore, in the US, to try and understand whether these types of interventions can really both inform, educate, engage, and improve, change, persuade, behavior change in children, to immunize them against chronic and other kinds of conditions later on. So we call it the digital vaccine. But today, I'm going to talk about the efforts in the context of adult health literacy. So before I start, let me just acknowledge my collaborators at different institutions in the US, Michigan State University, Arizona State University. We have deployment partners at Harvard Medical School, and of course, a slew of postdoctoral scholars and PhD students, as well as graduate students who are supporting participants and supporting this research. We've also been funded by the National Institute of Health, Division of National Library of Medicine, as an R01 grant. So just a quick overview, and what is this digital therapeutic approach, and why do we need it, and how do we then evaluate its impact? Those are really the issues I would like to focus on. But before we start, what is really the motivation that makes this question appropriate at this moment in time? And I think of it really as 3 phenomena that are converging. The first, of course, is the global burden of disease. We've just gone through the pandemic, and everyone is aware that especially patients with chronic diseases had really set of bad outcomes in recovery from COVID-19. So Lancet in 2020, for example, had this a summary that there's a perfect storm of rising chronic diseases and public health failures that really fueled and made that pandemic much worse than it's been. And at the same time, we also know that, we have a healthcare domain has a very large, history of tradition and history on looking at literacy and patient engagement, methods, tools, models, and so on to improve outcomes, but they really haven't had significant uptake. And then the third is what we look at, think of as supply as supply. The health literacy imperatives, we can think of it as demand. The rise of social media, mobile media, online visual media that are producing vast amounts of user-generated content, can we use them in order to develop these digital therapeutic methods for health literacy? That's we look at as supply. So if you think about it as a supply-demand context to address this worldwide public health challenge, we come down to this question: can we design and evaluate personalized, contextualized, just-in-time digital solutions to engage, to inform, and educate patients and the public? So this is really the key question around which we have developed a whole research set of challenges and approaches. So just to highlight each one of these, I'm probably preaching to a choir here, but we all know that, in the US, for example, more than 100 million people, a third of the population or half of the adult population, have been diagnosed with at least one or more chronic diseases. It accounts for more than 80% of the healthcare spending, which at the current time is $4.3 trillion in the US. And it's true in many other parts of the world. And we look at the global burden of disease, again, done through the Lancet publications and so on. And we see cardiovascular diseases and respiratory diseases as having a very high burden around the world, which is both chronic as well as infectious categories. So what is health literacy? Why this emphasis or this focus on health literacy? So in 2013, the Agency for Healthcare Research and Quality in the US has come out with a definition of health literacy with a futuristic perspective. And so personal health, and for the first time, they've defined two different perspectives on health literacy. The personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and for family members and so on. So this has been well known, well recognized. World Health Organization, the Centers for Disease and Control, and so on, the US, we all use this as the definition of health literacy. For the first time in the 2030 initiative, they've also defined organizational health literacy, which is the degree to which organizations equitably enable individuals to go out and get all this information and become empowered. So basically, it's saying that there should be an alignment and collaboration between individuals and organizations in supporting this goal of improving the health literacy of the population. And so in 2017, just before the pandemic, the US National Academy of Medicine came out with this report that said, those who speak for public health are clearly conscious of the importance of communication, not only for raising awareness and providing needed action steps, but also for earning and maintaining trust. And to begin, to be of high quality, the message must be accurate, specific, actionable, and easy to understand. So these are the requirements of a high effective communication, which, every study has shown that, our health systems failed at doing this during the pandemic. And so that brings us to our question. But before that, some facts about health literacy. Only 12% of the US adult population is considered to be proficient in health literacy. And the average around the world, it's not just the US, it's 13% internationally. Surveys have shown 13% proficient in health literacy, 73% low or problematic. in the US, more than 80 to 90 million people are deemed to have low health literacy. So, and in the UK, there are numbers for the UK, for China, for India, for Brazil, and so on. The numbers are not that different. And as I said earlier, lots of literature on ways to address this problem, but not very successful. Most of the major materials are really too complex for the average individual to understand. And in 2020, there was a study done at Dartmouth Medical School, where they looked at the health literacy, actually the reading levels of websites of state health agencies, the Centers for Disease Control, all the 50 states plus CDC. And what they found was that the reading level of all of these was at the 11th grade reading level, though CDC's own guidelines indicate that these should be at the 8th grade reading level. So they were violating their own best guidelines in putting out information about the pandemic to the public. So, and there are also health literacy intervention models that basically say, a whole bunch of opportunities for individual and for the professionals, and how do we really come together to be able to develop these interventions, deploy them, and evaluate them. And so that brings us to the third point, which is the rise of YouTube. We know that, more than 73% of the population in the US, for example, access YouTube in order to understand how to do things, and of course, for movies and other kinds of things. But it was really, I found it fascinating to learn that in the context of health education and communication, YouTube hosts more than 100 million plus videos on just health-related topics. And this is in the public domain. Publicly available user-generated content that is available for analysis, and these are on diagnoses, treatments, prevention, promotions, education, and it really has become the leading source, audiovisual source of health-related information. But there are some caveats. And basically, the criticisms basically say that it's information that anybody can upload. How do you distinguish between a video that's been uploaded by the medical school here versus a random person on the road? So the reliability of content, including information contradicting reference standards and guidelines, diabetes can be cured in 3 days. Curation of content, there's no organization that is really curating the content, and so it lacks a clear and consistent mechanism to retrieve high quality information. So I know that is high quality information. How do I get at it? How do I disseminate it? How do I give it to my patients? All of these questions are open up there. And so if you look at, so this is actually a video that on the bottom right, produced by, I think it is UCL Imperial College, the medical school. And it's, you can, and basically the point here is that there's a ton of data associated with these videos. When those videos are uploaded, when was it created? What's the channel that produced it? What's the content? Who produced the content? How many viewers? How many likes? How many dislikes? What language is it in? There's a lot of metadata associated with these videos. How long is the video? What's the language in which the video is produced? There's a lot of information. And so these are all factors that perhaps we can extract and we can use to be able to see if we can curate these videos. And so in response to this concern about the criticism associated with user-generated content, the US National Academy of Medicine partnered with YouTube to create watermarks and credentialing of identifying credible sources of information. That is, the idea was to surface authoritative content. And so in 2021, they set up a committee to develop criteria. And I was honored to be part of that, a member of that committee, where we identified credible sources, criteria for identifying credible sources of health information in audiovisual, social media content, And separately for nonprofit organizations like the medical schools, medical health systems, and so on, for-profit organizations, as well as individual sources, physicians putting out, patients putting out YouTube videos, and so on. And so we have developed a whole set of criteria associated with identifying credible sources of information. But these are all books and chapters and papers and text sources. How do we translate that to actionable information in the videos, so that I can, at the end of the day, I want to be able to identify good videos and recommend them to end users. So that brings us to our question. Digital therapeutics, is there a digital therapeutic approach for health literacy and patient education? So what do we mean by digital therapeutics? The idea is, can you utilize a digital or online health technology to treat medical or psychological conditions with the intent to persuade behavior change? That's really what a digital therapeutic solution is. So can we design an AI-enabled recommendation systems to retrieve appropriate user-generated content for this objective of patient literacy? So what do we mean by appropriate? And the approach that we are using is, we want to develop scalable, replicable, algorithmic solutions to evaluate YouTube videos or curate YouTube videos from health literacy and patient education perspectives. And for this, we combine health informatics, machine learning methods, and social science methods in the evaluation to aid clinical decision-making and perhaps even patient education via ranked recommendation, where this is really delivered as a prescription. So the vision really is that, well, when I go to a doctor's office, I'm diagnosed, let's say, with early signs of pre-diabetes. I don't know what is pre-diabetes. The first time I'm hearing about it. What should I do about it? Well, the physician might say, well, I'm going to give you a prescription for metformin, an early, first-line therapy for diabetes. What is metformin? I don't know. Well, along with the prescription for the medication, here is a prescription for 3 videos. These are short videos in the English language or in language of choice, for 3 to 4 minutes long, that have been curated, approved by the clinic for their patients. And those 3 videos are sufficient to kind of give me this early education on what diabetes or pre-diabetes is, why should I take this medication, and so on, in very easily understandable, consumable manner. This is really the vision. So how do we get there? How do we really address this issue of curation? So curating large volume of social media content. And so the specific questions we are asking is, does the video contain medical information, or is it just advertising fluff? Is it understandable at the 5th grade level, at the 11th grade level, and so on? Does it provide actionable guidance? That is, once I'm diagnosed, what should I do? Or what if I run into a health issue, what should I do? Is the information accurate? Is the source credible? Is it inclusive and representative of the population that it's targeting? Is it fair and unbiased? Is the medical information accurate? So all of this, especially these days, we are concerned about misinformation and so on. These are all the questions that we want to filter these videos through. So how do we do it? So I'm going to give you an idea. I'm going to, what did I do? But before I get to the approach, I'd like to give you this idea of what's happening here in the UK. A few years ago, I was in Cardiff to do a talk, and I had this conversation with colleagues that said they are really trying out this experiment where you're doing recommending cycling as doctor's orders. So basically, the NHS Wales had a partnership with your ride share, the bike share, right? The bike share program, where the patient gets a prescription from the doctor to get 2 bike rides for free every day for 30 minutes. And so they could use it. And for a few months, they were trying it to see whether, again, you could think of it sort of a digital therapeutic approach. It's actually an exercise-based approach by the clinician. So the idea is to engage the clinicians, make it easy for the clinicians to work with their patients to improve exercise habits. And similarly, in other examples that we have seen. So taking these ideas and applying it in the digital context, we are asking three key questions. How can we extract medical information encoded in the videos on YouTube and assess their understandability, actionability, all of those criteria that I've just outlined? How do we then measure its impact on users? And for that, we use a measure of collective engagement as a proxy for how users understand and interact with health information on the YouTube platform. And the final piece is really, what is that impact? How do YouTube videos curated for these for all these criteria affect collective engagement? So this is really what I'd like to walk you through very quickly. And we use a design science approach. And this was actually, design science was originally proposed by Herb Simon, that you might all be familiar with, one of the fathers of artificial intelligence, Nobel laureate at Carnegie Mellon. He basically said that in order to really evaluate impact, you need to create artifacts and put them out in the environments in which they get used. So first of all, you need to create the artifact. So we are using this to develop this approach to develop an automated YouTube-based educational video retrieval system with a focus on all these criteria, and then to be able to do the evaluation. And this really goes through 4 steps. So at this point, it's now become an engineering exercise. We really want to identify how to prepare the data, how to process the videos, how to classify the videos, to evaluate videos into high understandability, low understandability, high actionable guidance, low, and so on. So curate these videos for each of these criteria, and then to be able to evaluate both expert evaluation as well as causal evaluations of impact, so that we can then recommend these. We create a corpus of videos that are available to clinicians to recommend at the point of care. So, so let me just first give you the summary of this analysis pipeline, and then I will illustrate using medical information and understandability as 2 cases. So collecting the data, publicly available data, it is, you start with some search terms, and for these search terms, we actually go to discussion forums where patients engage with each other, asking questions. Clearly, patients are coming to these discussion forums because they're not getting the answers in the clinician's office, in the hospital, online, and so on. So they ask each other questions. How do you manage? Do you have these reactions, and so on? So we collected 200 search terms, and then we use those search terms in the YouTube data API to download both YouTube metadata as well as the content data. And then we use open access face recognition and data collection tools in order to do gender and age and classification, to be extraction in order to do identification of individual narrators in the videos. And then we do this multi-view video assessment in the context of medical information. So does the video contain medical information? We do medical term extraction using the BioLSTM deep learning network, and then classify that encoded medical information. So all the terms labeled and then annotated first, and then we train the BioLSTM model to extract these terms and then classify based on, does the video contain medical information versus not? High levels of medical information versus low levels of medical information. Is the information understandable? Here we use a multi-view learning co-training approach, and I'll go through this in a bit more detail in the next few slides, to do video understandability evaluation. Again, videos that have high levels of understandability versus low levels. Actionability assessment, does it contain guidance? Again, we use vision transformers to be able to extract actionable guidance in the videos and then classify the videos. We have also done medical misinformation to be able to classify videos that have, based on use of large language models and transformers, to be able to classify videos that have high levels of misinformation versus low. And finally, we haven't yet started, but we want to be able to do source credibility assessment for for-profit, non-profit, and individual, using the criteria that was developed as part of the committee where I served to develop these criteria. So once we have filtered the videos through each of these steps, it goes to an automated, can this video be recommended as a patient education tool? If so, what would be its likely impact? And so we do have this engagement, collective. We don't have access to individuals watching the videos. We only have the likes and the views and the comments and so on. So that's where the collective engagement measures come in. And so we extract those measures. We do principal component analysis to identify that the key levels of engagement, to multi-treatment propensity score matching, to be able to identify the factors that are relevant in the impact assessment. And we are also now planning to do think aloud and randomized field experiments, taking these videos as the intervention to look at the impact on learning at the first level, and then engagement and so on. And then once that information is given, you can imagine it goes into a corpus of approved videos that are then available for the clinician during the encounter with the patient, and then be able to write a prescription. So overall, this is really the pathway. And so we have actualized much of this and working on the credibility assessment, also doing a number of causal studies and impact assessment, but haven't yet started the think aloud and randomized field study. So this is the overall idea about how we are going about. So now to get into some of the details. Have time until 1 o'clock?
If you want to have some time for questions, maybe a bit less.
It's already 12:50 now. Okay, I'll give you just a flavor of the way we are going. So why diabetes? Well, it's a huge chronic problem around the world. Just in the US alone, more than 30 million diabetics diagnosed, more than 85 million pre-diabetes, and very high cost management condition. So we, as I mentioned, go through collect the search terms from questions asked in online health communities, categorized in different aspects of education, on diagnosis, on treatment, on management, on medications, and so on. Consolidate these search queries about diabetes, and for each term, get access to the top 50 videos. Now, diabetes has a large number of videos. So top 50, you can get quite a good collection of videos across these terms. But for rarer conditions, you might go just to get maybe 10 videos, 15 videos, and so on. And collect both the video metadata and the video content. This is just a quick summary of what the information collected on likes, dislikes, duration, whether the video has title tags, and so on. And from a research perspective, when you look at assessing health information quality, much of it has been done manually. There's really no effort before this to get at this information in an automated way. And if you look at the measures that you really need to look at, how do experts actually identify quality? What are popularity-driven measures? I look at the number of people who have watched the video, I look at the comments on the video, and I get a sense for whether this video is popular or not. And then heuristic, if it's a very long video, 15 minutes, 1 hour, it could be by an expert and not really a 5-minute educational type of video. So we can use some of these heuristic measures as well. But of course, this is human intensive, it's expensive, time consuming, and it's not scalable. So how can we develop a scalable framework? And so we have converted the approach that we have used is that it's a traditional machine learning at this time, but for some of the misinformation and the later work, we are really bringing to bear some of the capabilities of LLMs. But in this work, it's extract the features, map the features to the guidelines associated with understandability, actionability, and so on, and then build classification models. So that's really the strategy across many of these criteria. So heuristic-driven measures, you can imagine extracting duration, title, and so on. The expert-driven measures is using the BILSTM model. Are you all familiar with UMLS, the Unified Medical Language System? So this is, so UMLS is a set of software and resources and frameworks that have been assembled by the US National Library of Medicine that brings together vocabularies and standards from around the world that have been developed for healthcare. So diagnoses in the UK versus the US versus Japan, the standards that are developed could be different. How do we bring it all together? So UMLS has created a set of knowledge sources, a lexicon, a dictionary, a set of a semantic network that links myocardial infarction is the same as heart attack, common language as well as clinical language. So it's actually a set of resources, health informatics resources that allow us to link language components in a very systematic and rigorous manner. So for example, you have a relation treats that links the disease diabetes with something like metformin. So diabetes is treated using metformin. We can extract that using the UMLS repository. And so we extracted, we labeled, so we extract the transcripts from the videos, and 1,000 out of the 7,000 sentences that we extracted from a subset of the videos were labeled by clinicians using the UMLS guideline. That is, this is a language, this is a treatment for diabetes and so on. And then we trained the BILSTM RNN model, where we use medical terms like diseases, treatments, conditions, and so on, and included both the clinical language as well as the consumer health vocabulary. As I said, this comparison between myocardial infarction and heart attack. One is more the clinical terminology, the other is the what a common person uses it, and so included both these terminology. The model was trained on 4,000 annotated sentences, and 1,000 sentences were used for validation, and I'll show you the results later. And so when you aggregate all of the features that are extracted, including a relevance score, which uses the cosine similarity between the search query and the terms that is in the description, the title tags and description, because you want to ensure that the video that is retrieved is aligned with the query that you have. If you want something on diabetic retinopathy versus just diabetes, you want that cosine similarity measure to really come out high for those videos where there is that alignment. So we use these features to build a classifier. So before I show the results, let me quickly also go through the understandability. A video is considered understandable if consumers of diverse backgrounds and varying levels of health literacy can process and explain key messages. How do you do it now? Well, there is some things called teach back method. You know, the nurse explains to you what is diabetes and asks you to repeat it back. Did you really understand the terms, the management of it, and so on? It's not scalable. And so what we do is we use this, there are frameworks that have been developed again in the health informatics literature by the Agency for Healthcare Research and Quality, by the NICE guideline repository here in the UK, and so on, that evaluates and compares patient education materials in written, audio, and visual formats. And it highlights the need to emphasize the understandability of patient education materials. So these are 12 criteria, again, the same idea. And understandability is you aggregate the responses to these criteria to be able to compute the score for understandability. So again, we have taken these criteria, we have mapped them into features, the video metadata or the video content data using Google Video Intelligence and other tools, platforms, to really make sure that we have all the criteria mapped to features. And so this is the Google Cloud Video Intelligence platform that allows us to do object detection, the short change detection, speech transcription, text detection, along with the confidence scores. So all of these are features that go into the classification. You can compute then. So this is really an overall summary of all the different syntactic analysis, semantic analysis, readability analysis, optical character recognition. And so all the approaches that we have brought together in order to be able to extract features for the classification. And then the videos are a subset of the videos. We have 10,000 videos that we collected. 700 of them were annotated by clinicians as to whether they're understandable, whether it's actionable, whether it's as medical information, would they recommend it or not. And then we do apply this multi-view learning approach, which basically saying I take a small set of videos, I create two different classifiers, one for the metadata, one for the content data. And then for every new video that has not been labeled, I pass them through both of those. And if the both are in agreement as to whether it is a high understandability or low understandability with high level of confidence, then that becomes the label of that unlabeled video. So this is the case when labeling is very expensive and you really want to be able to use a small amount of data to label a large set of videos. And then, so how do these perform? Well, we applied logistic regression as our two classifiers in the multi-view learning approach. It turns out that things like the duration of the video, we don't want videos to be a very large duration. That really reduces viewing and engagement. Readability of the content is very important, both for metadata view as well as the content, video content view. So the confidence in the transcription, the confidence in the text detection, the summaries, does the video really summarize, chunking in terms of being able to understand and memorize. So these are all tied to cognitive learning theories as well. So again, just to summarize the results, the medical term extraction, we compared the YLSTM against the conditional random field model and the UMLS lexicon. It performed quite well. And then the classification, taking those terms and combining it with all those heuristic features from the video, overall accuracy was quite acceptable. It classified high medical information from low medical information videos. And similarly for understandability, classification, the co-training approach with logistic regression performed quite well in comparison to other traditional machine learning methods. And then you put all of these together, the understandability, the relevance of the video, the medical information, is there medical information? And it turns out that understandability has the highest importance in this analysis. So this is just showing, how the videos get assigned the label. And then we also compared, we gave a subset of the videos to clinicians to evaluate against and compare against the YouTube ranking. So we used a precision at K measure, which is very common in information retrieval. So when we found that 30% of the top ranked videos in understandability, whereas none of the top ranked videos by the YouTube default ranking. Similarly, 72% of the top 10 ranked videos by the automated method against the 40% based on the YouTube default ranking. And then maybe just 2 minutes for the last piece of impact assessment. So now we have classified these videos. We have high understandability, low, high medical information versus low. Does this classification really have, how does it affect engagement? And so this collective engagement is we use principal component analysis to consolidate all of the different features of likes, dislikes, what we call these extrinsic measures. Once the video is uploaded, you have all of this information into dimensions of engagement against the video classification as a treatment to characterize the video. And let me skip this to summarize that the principal component analysis identified 3 dimensions of engagement. There are people who just don't engage at all. There are people who engaged in segments of the video, so we call it selective attention-driven engagement. And then there are folks who really have sustained attention-driven engagement. And this is the propensity score matching estimates. But just to summarize, basically what we find is that the video understandability has a negative impact on engagement. So basically, if the video understandability is low, then the engagement is very, very poor. High understandability can help high medical information videos become more engaging. And high medical information videos with low understandability are the least engaging. So this aligns with our common sense understanding, but this helps us to quantify really, which is the most significant, and why should we really understand or analyze understandability, actionability, medical information, and so on in order to really improve engagement. And the last piece is really the policy, perhaps the policy implications. And this is just from a 2x2, the medical information understandability. If you look at the medical information low versus high, understandability low versus high, clearly what we want is high understandability, high medical information. That's a given. So we have the videos in there. We can then put it through the next calculation and so on. And this one, medical information low and high, for them out. We can figure out what is it that we can learn about guidelines. Don't produce these kinds of videos. When the understandability is low, but the medical information is high, we know that engagement is going to be very low. But those videos, when the understandability is high and the medical information is low, those are the dangerous ones. That we really want to look at those videos to see what is it about it that is so engaging that viewers go away with the idea that this is really persuasive, convincing, and can cause behavior change. So we are looking in particular at those to see what are the levels of misinformation and misleading and disinformation that we can extract from those videos. So this 2x2 matrix allows us to classify those videos into those groups and then to be able to extract more insights from the ones that are potentially dangerous for education public. So so we are now looking at experiments and so on. So I will stop there and thank you for your patience and your attention. Happy to take it.
May I ask a question about understandability? Because I noticed that when you do the annotation, it's actually annotated by like clinician. It's
Nope.
not like annotated by like patient. Just from my perspective, because I have no knowledge about that, just should the understandability judged by the patient itself?
It's both. We have the medical information is annotated by clinicians, but the understandability annotation is both by clinicians and by consumers. So we got graduate students, even though that's not the perfect population. We should actually go to patients, patient forums to do this. But in this effort, we got graduate students to take it. So we have both. But in the upcoming studies, I have a study with on polycystic ovarian syndrome, which is actually becoming a very big problem for young women around the world. And there we are getting a population of women diagnosed or at risk of polycystic PCOS to be able to annotate the videos. And they're giving a very interesting feedback.
A really interesting talk. I'm now questioning my healthcare literacy based on the percentage.
I asked my students in class, how many of you know these things? No hands go up. So I'm not surprised.
So my question is, as someone who writes technically, and then they ask us about lay summary, I can feel that there will be a lot of oversimplification and maybe inaccuracy when we translate from a highly technical jargon, full of jargon text to a lay summary. So like when you want to compare your videos, wouldn't that happen? Like if the understanding is higher, the inaccuracy might be higher as well.
So we are not talking here of summarization. We are looking at the transcripts of these videos. So the video has the narratives. And we are looking at the narratives to see whether the narrative, the description of the video is understandable to the average individual. So we are not really summarizing it for conveying perhaps the key ideas in that time. We are just taking the narratives as they are to assess the level of understandability of how that information has been expressed in that video.
Is your question one where the topic is complex that it cannot be reduced to a level below some level of, I mean, like going to a level where it's understandable, you're going to give up something in terms of conveying what it's about? Is that your, there's this trade-off between understandability and being able to convey?
Yes.
Is it irreducible beyond some point?
No, so you can get videos at the full spectrum of complexity, from 2-minute videos to 1 hour by the experts, where the full complexity of the video of the topic is expressed in accurate detail. The question is that, and maybe, so I know patients undergoing breast cancer treatments indicating that they want to understand everything about the treatment that they're going to go through. And they start with just these 1-minute, 2-minute videos or documents to really rigorous clinical trial, papers talking about those. So the question is, what's the need of the moment? Is it for this 2-minute understanding of what prediabetes is versus a deeper level understanding of the condition? And so then you will go to the video. So at that point, there really is we are not really looking at, should we take that complex, longer narrative and condense it down to, something that's much more understandable? That's possible, but that's really, if videos are available at all levels of complexity, we just want to be able to find the right level to match it for the needs of that individual.
Would there be less understandability or engagement with the high technical ones?
Yes, that's what our experiments are showing, that as understandability goes up on average, that is going to go down. So the other point I want to mention, going back to that accuracy, is that at the end of the day, this whole effort is only to reduce the task that clinicians have to go through. Instead of evaluating 10,000 videos manually, now they can look at 30 videos manually and then check for the accuracy of the content, whether it's appropriately stated, is it acceptable, would they be willing to recommend it to their own patients? So there's a final assessment that happens before this would actually be part of a course. So that's where the human intervention. So this is certainly not all automated. It's a human plus automated environment.
Yeah. I'm just sort of thinking, is there any sort of emphasis on sort of like, I guess, sort of safety critical information? We're talking about like injecting insulin, for example.
So I'm sorry, safety?
Like things where if there was like one piece of information in a video that was like incorrect or very dangerous, but the rest of it was very.
So that's interesting. So the latest work, which is undergoing review, is evaluating medical misinformation. And so what we are doing is that we are extracting sentence by sentence, matching it against accepted credible sources, the NICE guidelines, the CDC guidelines, authoritative textbooks, to make sure that every component, every sentence, then the question comes back. In fact, I was talking to my students, say, should we assess if one thing is wrong in the whole set, in the narrative, should we label it misinformation, or should there be a threshold that is applied? At the current time, we don't know. We just have the methodology in place, but we need to assess it with clinicians and domain experts. So maybe the information that is incorrect is a very critical piece of information. So how significant is that incorrect information? All of these are open questions. Other questions? Yeah.
So I know the current project is focusing on the YouTube videos and how to evaluate the video suitable for the patients and make the recommendation. I was wondering, there are many other platforms like Twitter or X now, which we use daily basis on the bus, on a communicated way. And also I know some experts, they write the long like blogs on the Medium. And I was wondering if in the future studies, we're looking at these platforms, will this information behave similar as the YouTube videos, or if it is something different? And when we recommend some of the blogs or some long threads, Twitters to the patients, and they have some different kinds of barriers for accessing this medical information.
So medical information is available in so many formats, right? In so many modalities and so on. The PMAT criteria that we're using for actionability assessment and understandability assessment have been developed and validated, trial validated for audiovisual materials. If you want to extend it to, standards exist for text materials. They've been there for a long time. But nobody has really looked at digitizing them, automating them, and so on. But those standards have existed for a long time. It's only in the context of this multimedia-rich modalities that these new guidelines have come out. So we can apply the same to videos produced by Sora and videos produced by LLMs and all of that, right? Same approach can be used. But then for blogs and other text-based materials, you might go back to just guidelines that have been established for text materials. Those exist also.
So I have a few questions. The first one is, so you said something about a sort of partnership with YouTube. Is that correct?
So the partnership is established by the National Academy of Medicine. Right. Yeah. So they, the whole idea was that YouTube has all of these useful videos, but curating them and accrediting them is a challenge. So the National Academy of Medicine said, once we come up with the criteria for accreditation, you should have like a watermark, or if you go to YouTube now, YouTube videos produced by medical school here at Edinburgh or Imperial or Oxford, you will see a star rating that it's actually a credible source versus something that is produced by somebody that has not been evaluated, assessed yet. Yeah.
I see. And so, I mean, obviously, this is probably up to YouTube, but would they just like assign a tag? Is that what it is to the videos? Like, this is credible, this is not credible.
So it's only the ones that it's only the positive. If it's credible, then there's a star rating.
Okay, that makes
Yeah, there's an accreditation tag that's part of the metadata of the video.
That makes sense. Yeah, thank you. And yeah, just another thought, because you were asking about some YouTube videos that people get involved with, but they look like misinformation. I mean, I personally have healed diseases in ways that my GP never told me about. I don't think there were any guidelines for that, and I have used YouTube videos for that I don't think would have been considered accredited. For example, I avoided any medicine, and it was mostly change of lifestyle and things like this, but that I have not seen on any guidelines. So I'm just saying, I mean, of course, this is just the guidelines, and it's not like anyone is forbidden from seeking something else. I was just maybe giving a bit of an insight because you had a small question there, regarding some videos that are, people get involved a lot with, but they look like they're misinformation, and some of it for sure probably it really is, but I don't know that.
Yeah.
So you can never be sure. Yeah, this is it.
So that's why you need a scalable, independently valuable kind of a platform. These algorithms are all transparent. And so when you put the video through that platform analytics pipeline, at the end of the day, okay, it's high understandability, but low medical information, high levels of medical misinformation, and high, very good actionable guidance. Then, so you have a label that associated with all of these videos that can then be used by policymakers, by video developers, by individual consumers as well.
Yeah. What I was trying to say is that you don't know always if it's information or not. It's even science, medicine changes, So
Yes.
when new doctors come up with a new idea, it's against the you know,
Accepted practice.
exactly. And it may look like misinformation until,
I mean, we learned that
Yes.
during COVID. Initially, a lot of misinformation came out about COVID.
yeah, for example, exactly. So all I'm trying to say, you cannot always know that what is labeled as misinformation.
That's right. So this changes
Yeah.
over time.
Yeah.
And so, so one of our studies is really looking at, looking at COVID videos over time from 2020 to 2023. And we haven't done the analysis yet, but you see the evolution of knowledge, the accuracy, the levels of misinformation, the guidance, everything changes.
That makes sense.
Yeah, none of it is static. That's why we need to keep on, doing these analysis over and over again, which is where a platform like this will actually come in. Any other questions? Thank you very much.
Give a round of applause to the wonderful Chai team for helping us plan everything.